Welcome to today's deep dive. We are tackling a topic today that is, honestly, it's pretty heavy, but it is so incredibly vital.
It really is, yeah.
Imagine surviving a grueling, life-altering battle with cancer. You make it through all the exhaustive treatments, you're finally entering survivorship, and you're just trying to reclaim your daily life.
Right, just trying to get back to normal.
Exactly. Only to find that the life-saving pelvic radiation you received has left you with a complication so agonizing that, well, one clinical study we looked at showed 98% of patients completely abandon their intimate lives.
Yeah, 98%. It's a staggering number.
It is. So today we are looking at the silent, often really agonizing fallout of those life-saving treatments.
It's a profound transition. For a long time in oncology, the primary focus, and understandably so, is just keeping the patient alive.
Right. Survival is step one.
Exactly. But as survivorship rates have thankfully improved, the medical field is really having to reckon with the long-term structural aftermath of things like pelvic radiotherapy.
Because it's not just a quick recovery.
No, not at all. We're seeing how treating one severe problem can set off this hidden cascade of really complex intersecting challenges.
And that brings us to the core mission for today's deep dive. We're exploring a highly specific, rarely discussed challenge in women's health and cancer survivorship. We want to answer a specific question. Can the severe vaginal dryness caused by pelvic radiation actually make the symptoms of vaginal laxity, which is, a loss of tissue elasticity and tone, feel significantly worse?
The short answer to that is a definitive yes.
Yeah.
But the mechanics of exactly how that happens are what make this such a vital topic to understand.
Right, the biological why is fascinating. To unpack this, we pulled together a massive stack of sources for you. We've got official guidelines from the British Menopause Society.
Those are incredibly detailed, yeah.
They are. Plus, clinical trial protocols and some really comprehensive patient information leaflets from major hospitals like the NHS and University College London hospitals.
And what stands out across all those documents is just this picture of a condition that is vastly underreported.
Because of the stigma, right?
Exactly. It sits at this sensitive intersection of oncology, gynecology, and sexual health.
Yeah.
And these are areas where patients naturally feel a lot of hesitation to speak up. They often assume that, well, chronic pain is just the tax they have to pay for surviving cancer.
Which is just heartbreaking. So whether you are navigating cancer survivorship yourself, or maybe supporting a partner through recovery, or even if you're just someone who's fascinated by the incredibly complex ways our tissues heal and react to trauma, you're going to want to stick around for this.
It's a fascinating look at the human body.
Let's start with the biological chain reaction that happens during treatment.
Sure. To really grasp the physical symptoms someone experiences months or maybe years down the line, we have to zoom way in on the microscopic environment.
Okay, let's zoom in.
When a patient undergoes pelvic radiotherapy, usually for things like cervical or endometrial cancers, the radiation is there to aggressively destroy the cancerous cells.
Right. But radiation, even with all our modern advancements, it still has collateral damage.
It does. At a cellular level, it affects healthy surrounding tissues, blood vessels, and nerves.
I saw in the clinical text they mentioned rare complications like lumbosacral plexopathy.
Yes, exactly.
Where the radiation damages nerve bundles in the pelvis and actually affects the legs.
Right. That can happen. But the most universal and really significant impact for our discussion today happens if the radiation field includes the ovaries.
Because if the ovaries get hit by radiation, they essentially shut down, right? They stop producing hormones permanently.
Yes. The radiation effectively induces a sudden premature menopause.
Wow.
And unlike natural menopause, which gives the body years to, gradually adjust to fluctuating hormone levels, this radiation-induced menopause happens almost overnight.
So it's a massive shock to the system.
A total shock.
Yeah.
You get this drastic plummeting drop in systemic estrogen. And for the vaginal ecosystem, estrogen is the absolute master regulator.
Okay, I want to understand that ecosystem better. I was reading through the University College London hospitals leaflets, and they keep talking about the disappearance of glycogen after this estrogen drop.
Right, glycogen.
I have to admit, I had a gap in my knowledge here. What does a type of sugar have to do with maintaining vaginal health?
It's actually a brilliantly designed loop. So in a healthy premenopausal environment that's supported by normal estrogen levels, the lining of the vagina, the superficial epithelial cells, they're constantly turning over and shedding.
Kind of like the skin cells on your arm.
Very much like that, just constant turnover. And as these specific cells shed, they release large amounts of glycogen. which is, like you said, a stored form of sugar.
Okay.
That glycogen serves one crucial purpose. It's the primary food source for the healthy bacteria in the vagina, predominantly lactobacilli.
Oh, wow. So the body is actively feeding its own microscopic flora.
It is, and in return, those lactobacilli digest the glycogen, and they produce lactic acid as a byproduct.
Which makes things acidic.
Exactly. That lactic acid keeps the vaginal environment at a low, slightly acidic pH, usually somewhere between 3.5 and 4.5.
Right, I've heard of that.
And this acidity is the body's natural defense mechanism. It makes the environment completely inhospitable to harmful bacteria.
But then the pelvic radiation happens, the ovaries shut down, and the estrogen levels just fall off a cliff.
Right.
The pathology reports in these clinical protocols show that because of this sudden estrogen deficiency, the tissue lining becomes incredibly thin. There's a massive reduction in those superficial epithelial cells.
Yeah, they drop down to less than 10% of what they used to be.
That's a huge drop, and when 90% of those shedding cells just disappear, the glycogen vanishes with them.
The food source is gone, completely wiped out.
So the lactobacilli literally starve.
Starved of glycogen, the lactobacilli die off, and without them producing that lactic acid, the pH of the vagina inevitably rises above 5.
It becomes alkaline.
Much more alkaline, yeah.
The texts mention this allows commensal organisms to take over. What does that actually mean in this context?
So commensal organisms are just the everyday microbes that naturally live in or on our bodies without normally causing harm, like certain strains of E. coli from the digestive tract, for example.
Okay.
In a healthy, acidic vaginal environment, they're kept completely in check. But when the pH rises and the lactobacilli are gone, those commensal bacteria seize the opportunity, they multiply rapidly and become the predominant flora.
To put an image to this, it feels like we're looking at a lush, highly regulated rainforest that suddenly loses all its rainfall.
Oh, that's a great analogy.
Right. The canopy thins out, the rich soil completely dries up, the vital flora dies off, and the entire local ecosystem just flips into a harsh, arid desert.
That is exactly how you should visualize the cellular fallout. You're left with an environment that is profoundly dry, structurally thin, and chemically altered.
Wow.
And this harsh new reality sets the stage for the really confusing physical symptoms that patients experience next.
Wait, I actually need to stop you right here. Because I was looking at the official guidelines, and I am genuinely confused by a massive paradox in the symptoms.
Okay.
Vaginal laxity is pretty universally described in these texts as a feeling of looseness, like a loss of physical tone.
Right, usually from childbirth or aging.
Exactly. But the radiation side effects explicitly list a condition called stenosis.
Yes, stenosis.
And stenosis is the narrowing, shortening, and stiffening of the vaginal canal due to heavy scar tissue.
Correct.
So how can a patient have a narrowed, scarred, stiffened canal, but simultaneously suffer from laxity, which is looseness? I mean, those seem physically contradictory.
It's an incredibly astute observation. And it's the exact paradox that makes this condition so distressing and so difficult for patients to even articulate to their doctors.
It just doesn't make sense on paper.
Right. To untangle it, we have to separate the architectural space of the vaginal canal from the functional health of the tissue walls themselves.
Separate the architectural tunnel from the walls lining it.
Okay. Precisely. You're entirely correct that the collateral damage of radiation causes fibrosis, which is the creation of dense scar tissue.
Right, the fibrosis.
And this scar tissue can physically pull, shorten, and narrow the overall cavity. That's the structural stenosis.
The tunnel gets smaller.
Yes. But the mucosal tissue lining the inside of that narrowed tunnel, that tissue is suffering from severe estrogen deprivation. So it's completely atrophied.
Ah, I see. The clinical protocols mention that the fibroblasts, which are the specific cells responsible for producing collagen and elastin, they actually stop working.
They do.
They become dormant cells.
Yeah.
Right, called fibrocytes.
Right. Without estrogen to stimulate them, the whole factory just shuts down. Collagen provides structural strength, and elastin provides stretch.
Yeah.
So without them, the tissue loses its rubber band quality, it becomes incredibly fragile and paper thin, it can't stretch, and it can't snap back into place.
So if I'm understanding this, it's like walking down a very narrow, constricted hallway, but the drywall itself is crumbling. It's completely devoid of any structural integrity.
That is exactly what is happening. The overall space is narrow, but the walls are functionally weak, loose, and lacking any intrinsic tone.
And that weakness is the laxity.
Yes. Now, we have to look at how the profound dryness from our arid desert ecosystem interacts with that crumbling drywall.
Because the core focus of our deep dive today is whether that dryness makes the laxity feel worse.
Right.
Under normal circumstances, the primary complaints regarding laxity are just a decrease in physical sensation and a lack of supportive friction.
But when you add the extreme radiation-induced dryness to this severe lack of elasticity, the physical mechanics completely break down.
How so?
Normally, natural moisture acts as a crucial barrier. It allows tissues to glide smoothly against each other and accommodate movement.
But here, there is absolutely no moisture barrier.
None at all. Without lubrication to allow gliding, and without the collagen-based elasticity to allow stretching, the tissues are subjected to immense, localized shear force during any kind of friction.
Oh, that sounds awful.
The medical texts describe the vaginal walls in this state as pale and friable.
Friable. That means the tissue is so delicate that it tears or bleeds with almost no provocation, right?
Exactly. So the functional weakness of the laxity, combined with the total lack of a moisture barrier, transforms what would normally just be a feeling of looseness into intense, highly localized friction, irritation, and physical trauma.
Wow. So the dryness actively amplifies the tissue's inability to support itself.
If it does, because the tissue is loose and lacks tone, it bunches and drags rather than stretching smoothly.
Ugh, dragging.
Yeah. And because it's completely dry, that dragging actively causes micro tears in the friable tissue. It's a compounding effect where the lack of moisture makes the lack of structure exponentially more damaging.
Which leads us directly into the devastating real-world impact of this compounded condition. I mean, the consequences for a patient's quality of life are just staggering.
They really are.
We're talking about severe dyspareunia, which is the medical term for extremely painful intercourse, recurrent micro tears, and postcoital bleeding.
And we have to acknowledge the heavy emotional weight of this, too.
Absolutely.
These are individuals who have endured the terror of a cancer diagnosis, survived grueling treatments, and they're just trying to rediscover their intimacy and physical connection.
And instead, they're met with this physical barrier that causes agonizing pain.
Exactly.
You see this so plainly in the Bojanini study referenced in the clinical trial data. This study specifically observed patients dealing with post-gynecological cancer symptoms.
Right, the 98% stat.
Yes. They documented that before receiving any restorative treatment, 98% of the patients in the trial had avoided having sex entirely because the symptoms were so severe.
98%. It's a heartbreaking metric that perfectly illustrates the silent toll of survivorship.
It really is.
And if we look closer at the mechanics of pain, we see that it's not just a localized physical problem. It creates a powerful neuromuscular feedback loop that basically traps the patient.
Let's unpack that, because I noticed the British Society of Sexual Medicine uses the term genitourinary syndrome of menopause, or GSM.
Yes, GSM.
What does that umbrella term actually cover, and how does it play into this feedback loop you mentioned?
So GSM is the updated comprehensive term for all of these intersecting issues. It covers the dryness, the laxity, the burning, the irritation,
Okay.
as well as urinary symptoms like frequent UTIs or urgency, which all stem from that exact same localized drop in estrogen.
I see.
When a patient with severe GSM attempts intimacy, they experience that sharp tearing pain we discussed.
And obviously the brain remembers that pain.
Exactly. The brain rapidly learns that this specific activity equals trauma. So the next time, there is profound anxiety and anticipation of pain.
Right.
And when you're anxious and expecting to be hurt, your body's involuntary autonomic defense mechanism is to tense up.
Muscle guarding.
Yes, exactly.
Yeah.
The muscles of the pelvic floor involuntarily clench defensively.
Wow. Okay. So now look at the mechanical environment. You have structural laxity and highly friable tissues. You have severe friction from the complete lack of lubrication. And now, on top of all that, you have a wall of involuntary muscular tension fighting against any penetration or movement.
It creates a complete vicious cycle. The tension causes more friction,
Which causes more tearing.
which causes more pain, which reinforces the anxiety, which causes even more tension the next time.
It's just a self-fulfilling loop of physical trauma.
It is. And as the texts highlight, this level of severe GSM doesn't just isolate itself to intimacy.
Right. It's an everyday thing.
Exactly.
Mhm.
When the mucosal tissue is that friable and dry, just the ambient friction from going for a walk, or even the prolonged pressure of sitting in an office chair all day, it can cause burning and severe discomfort.
It literally affects what kind of underwear or trousers a person can even tolerate wearing.
Yeah, it becomes a constant lingering physical reminder of the cancer trauma, making it incredibly difficult to truly feel like you've moved into the survivorship phase.
Okay, so if the body is trapped in this vicious cycle, where anxiety, muscle tension, dryness, and physical fragility all compound each other. How do we actually intervene to break that loop?
That's the big question.
What are the medical therapies being used to combat the laxity and the dryness simultaneously?
Well, addressing this requires a multifaceted approach, usually starting with mechanical and hormonal interventions. And it requires a great deal of patience from the patient, as tissue remodeling takes time.
Looking at the NHS patient leaflets, the immediate mechanical solution they heavily advocate for is the use of vaginal dilators.
Yes.
These are essentially smooth, cylinder-shaped medical tools, graduated in size, and they're used with very generous amounts of water-based lubricants.
Their purpose is highly specific. First, the gentle, progressive stretching combats that radiation-induced stenosis and fibrosis.
The narrowing.
Right. By physically stretching the scar tissue over time, they help maintain the architectural length and pliability of the canal.
The leaflets also explicitly state that regular use of dilators prevents adhesions. What exactly does that mean in this context?
So an adhesion is a severe complication where the raw, inflamed, microtorn walls of the vagina actually begin to heal stuck together.
Oh my God.
Yeah, because the tissue is so damaged and constantly pressed together, the body mistakenly tries to fuse it. Regular, lubricated use of a dilator keeps the walls separated so they heal independently, maintaining that functional space.
Wow, okay. And alongside dilators, there's a massive emphasis in the literature on pelvic floor physical therapy.
Highly recommended, yes.
And based on what we just discussed about muscle guarding, I assume this isn't just about doing Kegels to tighten things up.
Far from it. In this scenario, the pelvic floor muscles are hyperactive. They're locked in a defensive spasm.
Oh, right.
So a specialized physical therapist works to downtrain those muscles. They help the patient actively rewire the brain-muscle connection, teaching them how to consciously identify the tension and intentionally relax those muscles.
Which breaks a massive component of that pain feedback loop.
Exactly.
Then we move to the hormonal solutions. The British Menopause Society guidelines strongly support the use of localized vaginal estrogen as a highly effective method for restoring moisture and tissue thickness.
Localized estrogen is incredibly efficient. It's applied directly to the tissue, usually via a cream, a small tablet, or a flexible ring, and it essentially replaces the specific local hormone that the radiation wiped out.
And crucially, it does this without significantly raising the estrogen levels in the systemic bloodstream.
Right, that distinction between localized and systemic is vital.
Because the sources are very clear that many survivors, particularly those who had estrogen receptor-positive breast cancers or certain gynecological cancers, are deeply terrified of using anything with the word estrogen in it.
And it is a completely valid fear. I mean, if your cancer was fed by estrogen, introducing it back into your body feels completely counterintuitive to survival.
Naturally.
However, the oncological guidelines support the safety of localized vaginal estrogen for many survivors. But they emphasize that it should be prescribed following a rigorous process of shared decision-making between the patient and their oncology team.
What happens when hormones, even localized ones, are absolutely medically contraindicated? Or maybe the patient simply refuses them.
Right.
This is where the medical interventions take a turn that honestly surprised me.
The energy devices.
Yeah, the clinical trial protocols pivot to using non-ablative energy devices, specifically fractional CO2 lasers and radiofrequency, or RF, therapies.
This represents a major frontier in how we treat these compounded symptoms without relying on pharmacology.
When I first read this, the logic seemed entirely backwards. I mean, using a high-powered medical laser to treat severe dryness and tissue fragility, it sounds like trying to put out a fire with a flamethrower.
It does sound intense, yeah.
But as I dug into the mechanisms, an analogy came to mind. Is using a laser in this environment essentially like taking a heavy machine to aerate a dry, compacted lawn, punching microscopic holes into the dead earth to force the roots to wake up and grow new, healthy grass?
That is exactly what the laser is doing. It's creating highly controlled, microscopic thermal injuries.
Okay, let's look at that cellular mechanism because it explains how we can actually reverse the tissue damage.
Right. So the energy from the CO2 laser is specifically attracted to whatever residual water is left within the thin connective tissue lining the vaginal walls.
Okay, it targets the water.
Yes. When it hits that water, it vaporizes it, creating a microscopic column of dermal damage. This sudden heat causes localized microedema, or microscopic swelling, over the next few days.
And why is that swelling beneficial?
Because it acts as a massive alarm bell for the body's immune system and healing cascade. The thermal shock essentially shocks the local tissue into a state of acute repair.
Ah.
Remember those dormant fibrocytes we talked about earlier?
Yeah.
The ones that shut down after the estrogen drop?
Yes, the closed down collagen factories.
The heat wakes them up. It forces them to transform back into active fibroblasts. This triggers a biological process called neocollagenesis, which is the rapid creation of brand new, healthy collagen and elastin fibers.
So by deliberately causing microscopic damage, the laser tricks the body into rebuilding the structural elasticity of the walls.
Precisely.
It fixes the crumbling drywall from the inside out, addressing the laxity.
And the healing cascade doesn't stop there. The thermal energy also triggers neovascularization, which is the formation of new microscopic blood vessels in the tissue.
Oh, wow.
Increased blood flow brings more nutrients and increases cellular turnover. Because of this, the stratified squamous epithelium, the paper-thin lining, actually begins to thicken back up.
And as the lining thickens, does it start shedding those superficial cells again? Does the glycogen return?
It does. As the tissue thickens and turns over, glycogen production resumes.
And the loop is back.
The lactobacilli return to feed on it. The lactic acid is produced. The pH drops back down to a healthy acidic level, and the natural moisture barrier is completely restored.
That is incredible. So by waking up the body's own localized repair mechanism, you're simultaneously resolving the structural laxity and the profound dryness.
It's a profound shift in how we can approach recovery.
It really is. Now, to remain completely impartial with the specific trial data we're reviewing, we must note a distinction in the technologies mentioned.
Fair point, yes.
While the studies show highly promising, robust results for CO2 lasers, particularly in studies involving breast cancer survivors, seeing major improvements in dryness, pain, and elasticity, the data on radiofrequency or RF devices is much more mixed.
That is a very important caveat. One of the clinical trial protocols explicitly warns that while RF is showing promise in the general, non-cancer population for vaginal laxity, it's currently considered not a proven therapy for these specific, severe post-radiation symptoms in cancer survivors.
Right, so the medical community is clearly still actively researching the long-term efficacy and safety profiles of these energy-based devices.
Definitely.
And it's important to note that it's not a magic one-time fix. It requires multiple sessions. But the underlying science of forcing localized tissue regeneration, it offers a non-hormonal pathway to healing that simply wasn't a standard of care a decade ago.
It represents an incredible step forward in prioritizing a survivor's quality of life, not just their basic survival.
Let's zoom out and recap the journey we've taken today. We started by looking at how life-saving pelvic radiation causes a sudden, drastic shutdown of the ovaries, leading to plummeting estrogen levels.
Right.
We saw how this microscopic cellular fallout starves the vaginal ecosystem of glycogen, destroying the good bacteria and leaving behind a harsh, profoundly dry environment.
A total desert. We then untangled that complex physical paradox. We learned that the structural narrowing of stenosis hides the severe atrophy of the vaginal walls.
Yeah.
The lack of estrogen shuts down collagen production, leading to functional laxity and weakness. And crucially, we answered our central question. Without a moisture barrier to allow gliding, that loss of structural elasticity turns into severe friction, friability, and intense pain.
The dryness absolutely amplifies the structural damage.
Totally.
And we witness the devastating real-world impact that this compounded condition has on a survivor. It creates a vicious cycle of physical pain, muscle guarding, and psychological anxiety that forced 98% of patients in one study to abandon intimacy.
It's heartbreaking.
But importantly, we explored as we wrap up this deep dive, I keep thinking about how far we've come from simply treating the immediate threat of cancer. We're finally mapping the complex, interconnected landscape of long-term survivorship.
And understanding the mechanisms of these regenerative treatments raises an incredibly important, lingering question for the future of post-cancer care.
What's that?
Well, if tools like non-ablative lasers and localized therapies can essentially reverse severe tissue atrophy by simply waking up the body's dormant repair systems.
Could the future of oncology involve routine preventative regenerative therapies?
Exactly.
Like, instead of waiting years for the tissues to atrophy, the drywall to crumble, and the agonizing pain cycle to begin, could we utilize these therapies prophylactically immediately following radiation to ensure these devastating late effects never have a chance to take hold in the first place?
Yeah, that is the exact frontier the medical community is heading toward next.
Something to ponder as we continue to rethink what it means to truly survive and thrive. Thanks for joining us on this deep dive.